Jamile, it's so good to see you on our first annual HemOnc Pulse podcast live meeting. Really a pleasure to be with you. So we did this session on the unanswered questions in MDS. Maybe just for viewers and listeners, summarize in your opinion, what are these top unanswered questions?
The field has changed really recently because we know a little bit more about molecular lesions within MDS and what they mean therapeutically. So I think that kind of translates to how do we define this disease, and this notion of pre-MDS is becoming kind of prevalent, like we used to think about MDS as preleukemia. So
I'm fascinated by this,
yeah,
pre-MDS.
it's totally fascinating. So now we're understanding a little bit more about that, and it seems to me that we're moving earlier and earlier into tackling some of those disorders based upon next generation sequencing and of course cytopenias. Classification schema will also change, also to incorporate some of the knowledge. So you've seen the changes in the ICC and the WHO, the most recent versions that incorporate, again, knowledge gained from next generation sequencing into defining MDS as biological subsets. So designation of SF3B1 and deletion of 5q and TP53 was not something that we had in prior classification systems, and I think that's very important. You're also seeing risk classification that incorporates molecular lesions in that, or molecular mutations. So now we have the IPSSM, and everybody who takes care of MDS patients is encouraged to apply those risk stratifications so that you can sort of recommend a better therapy. So that is by the wayside. And what's interesting also is that we're seeing novel treatments for patients who have this disease. So as I'm sure you know, the COMMANDS trial showed that you can now treat patients who have SF3B1 frontline. Now, if you didn't have an NGS, do not know that you have SF3B1, you probably would
So you really
lose.
have to do these things, right?
Absolutely. And then it'd be interesting to see if imetelstat becomes yet another option for low-risk disease patients to get them off transfusions, because we all know that transfusions are associated with worse outcome.
I have to say, one of the things that were really interesting and I learned from the session is the fact that, you know, it's no longer a nihilistic view of how we look at MDS. It's a true entity, true disease. Let's get to figure out how we treat it. That was my important take home for me.
Exactly, and I think we need to learn a little bit more about things like TP53. In my opinion, I still don't think that we have a slam dunk drug to treat this entity, but that's sort of like the holy grail of treating this disease and many others for that specific mutation. And I think we're all waiting for the results of the Verona trial. In my opinion, I think it would be wonderful if you could cement the data that were gleaned from that combination in the AML, in the MDS patient population. And I tend to feel like I'm one person who's waiting for positive results before I implement the combination for my patients. And I know I may be in a minority in that regard. But
well, thank you so much for coming. Look forward to having you next year. Thank you so much.